Hi, everyone. Thanks for joining. We are Michigan Center of General Medicine, and tonight's topic, what your insurance will cover, what kind of procedures we can do that insurance does allow us to, and then specifically we want to get into if you have pain after surgery, what kind of stuff can we do to help you? So tonight, specifically, we have a new team member, Dr. Rob Farhat, has joined us, and he's been gracious enough to spend the evening with us while we present to you all. Specifically, we have a new Dr. Farhat.
Hello, everyone. My name is Rob Farhat. I am a physiatrist, interventional pain specialist, just like Dr. Santa Ana and Dr. Navity. I've been doing this practice of medicine for 15 years now. I grew up locally, and I went to Michigan State. I went to U of M for training, and I'm back in the area for the last 15 years of practice. So I am enjoying this wonderful practice.
We've been working with Rob, trying to pull him over for couple of years now. We in very much the same circles with patient care, Metro Detroit, East Side, in particular, both your former practice, my former practice. We shared a lot of patients, have a lot of respect for this guy, so very, very pleased to have him as part of the team.
Great reputation, great skill set. Great to have you on the team.
Yeah. So I guess without further ado, we'll kind of just jump into the next topic. Nothing real formal that we want to try to address. It's just we get the question a lot where we do regenerative medicine, we do a lot of things that insurances don't recognize yet. Do you guys accept insurance? Is there anything that my insurance will pay for that you do offer? And absolutely. I think that's one of the things we pride ourselves in is we're not just a niche practice, meaning we don't just do stuff that insurance doesn't cover or stuff that your insurance covers. We talk to you about the entire spectrum of things that you might benefit from.
And we try to optimize anything and everything that your insurance will cover. So from your office visits, from insurance covered procedures, we try and give you options that insurance is covered, but we also give you options that insurance is not covered. And it kind of gives us this bigger repertoire of tools to use. But today's topic is insurance procedures that we have.
So it starts with that consult. We do accept insurances almost. I want to say every insurance in the area. There's hundreds of insurances, so we can't be on every single insurance panel, but we do our best to try to be available as much as we can. When you call the office, our staff is continually getting better at making sure that we do everything necessary in order to accept your insurance for that consultation. And then that's where really the first step of deciding what the right step for you or the right treatment for you is going to be is that consultation treatment, where we'll spend time getting your history, doing a physical exam. Please bring in your imaging. If you have imaging, we all like to look at it. Dr. Farhat in particular is very good at reviewing MRIs, and I've learned a lot from him just in the couple of weeks that he's been here. What to look for on those MRIs that help us really determine what your pain generator is and what options you might be able to benefit from. So I think maybe we just start with a couple examples. If we'll put the new guy in the spot. If a patient comes in with a low back pain problem, what kind of things would you be interested in looking at, and what kind of options might you be talking to that patient about, especially geared for tonight as to what their insurance might cover for them?
Yeah, so a lot of times, sometimes when people have back pain, it's not necessarily their first episode. It's been either one or two episodes, and maybe this time it brought them to the doctor. So as physiatrists, as our specialty teaches us, we start from the beginning. What happened? How did it start? All the basic history information. What have you tried at home? And just like Dr. Navity said, we try to utilize what insurance we can, but sometimes that restricts us. So sometimes patients have to go through the physical therapy. They have to go through some stuff that may not necessarily always work right away, but it's something conservative to try. Eventually, based on insurance, that'll cover the imaging. You have to do a few weeks of therapy, order imaging, have you come back if you haven't improved. And at that point, we would discuss options. The standard treatments such as cortisone injections, sometimes test injections, sometimes treatments that may not last long-term. We try to look at long-term options. And then maybe we can discuss these considered alternative treatments that may look at regenerative options, or maybe people don't even want to consider the standard treatments. They want to move right toward the regenerative options. So we try to look at the gamut of options for treatment, not just one specific.
Yeah, so you mentioned something about a test injection. What do you mean by a test injection?
Sometimes we're trying to decipher what the source of the symptoms are. So when we look at imaging, it's not always clear what is causing the pain. Sometimes we think we know, but we're not always right. So sometimes instead of a cortisone injection, we'll do an anesthetic injection. People know it as maybe a Novocaine injection like they get at the dentist, in order to identify what the source of pain is. Then, once we determine that, then we can figure out what the best course of action is.
Yeah, you're right. Because like most times, like people come in, it's really complicated, right? It's like multiple structures affected, especially if it's like a chronic condition that you've had for many years, and you've had degeneration in multiple areas, other defects also. Doing that diagnostic block makes sense because they're able to kind of pinpoint exactly which is the pain generator. And usually, a lot of the outcomes that we get is because we're able to find that main generator pain, and that's what makes things successful.
Yeah, so couple terms, facet joint, lumbar disc issue, an SI joint issue. Those pain syndromes oftentimes overlap, like where the pain feels, what makes it better, what makes it worse. Imaging can be hit and miss, and the last thing we want to do is offer somebody, if we're doing like a PRP or a regenerative type injection, is put the PRP regenerative substance in the wrong spot.
Yeah.
So using those diagnostic pain blocks, which your insurance will cover, oftentimes is the first step to making sure we're doing the right regenerative injection.
Yeah.
Getting a good outcome from your regenerative injection involves really 3 steps, and one of those 3 is putting it in the right structure.
Yep. I had a patient that came in just a couple of weeks ago. He came in primarily for knee pain. After doing the examination, kind of looking at different things, it turns out he actually has like a really straightforward radiculopathy. So it's radiculopathy is a pinched nerve in the lower back that's causing refer pain to his knee, and it's not really his knee that's the issue. Even after he did have some pathology in the knee, but primarily it's the lower back that's kind of generating that. So we did a test block. It was just an anesthetic just to kind of rule it out. And lo and behold, we're still having some issues. So kind of.
Speaking of that, I had a woman yesterday, 77-year-old woman. She fell, hurt her wrist, and she's been seeing doctors now for a year, right? People said it's a carpal tunnel syndrome, it's arthritis, etc. She saw a hand surgeon. He really didn't give her an answer. She came to see me. She said her doctor gave her a shot in her wrist. It worked for 3 months. So that sounded like, well, it sounds like it's the wrist. So instead of giving her another cortisone injection, I said, you know what, let's do a diagnostic injection to confirm that's the pain. And sure enough, it's her wrist. Now, instead of surgery or more cortisone, now we're talking about regenerative options, because realistically, at her age, she deals with the pain, or she potentially gets a fusion of her wrist, right? So that's her dominant side. So it didn't really make a whole lot of sense to go down the surgery route. And as soon as I did the injection, we saw that there was a tear in her wrist, the structure of her wrist. It was pretty obvious. It was an arthrogram. So I was like, oh, and it worked. So it's perfect. That's exactly what we try to figure out.
So it's really where this field, this regenerative medicine field, is really emerging. And you brought up earlier, right now it's fitting very much in that kind of intermediate patients that typically don't respond to what we consider to be standard of care right now. But boy, they don't want that surgical option of wrist fusion. You're going to lose all really motion and function of that wrist. And those are the patients that are for the most part, choosing the regenerative option. But one of the things you said earlier, there's no reason people have to jump through those hoops of physical therapy, of cortisone shots, of 6 months to a year of failing treatment and dealing with pain before they can do the regenerative option. We run into that quite a bit. When you take insurance out of the mix, if you want to put regenerative ahead of those things your insurance covers, there's no reason you can't. And that's becoming and emerging as more of the standard of care. Rather fix the problem rather than just mask the pain. Pain is a privilege, your body's way of saying something's wrong, rather than just taking that pain away but not actually fixing the underlying problem. Wouldn't it be better, Doc, just to regenerate the tissue from the get-go.
Yeah.
I don't have a good comeback to that. You're right. It would be better. We just, by virtue of training, by virtue of habit, we just assume everybody wants to do what their insurance covers first, which doesn't have to be the case. And to be honest with you, isn't always the best option for people.
Yeah, that's true. And just having all these tools in hand that we can present to patients definitely opens up a whole new world of possibilities.
So kind of along some of the diagnostic stuff after the spine, there's a procedure called a radiofrequency ablation that we will do a lot of, which is a more long-term nerve block. I don't know, John, you want to take that one?
Yeah, so typically we do a diagnostic block in the lower back for more pain that's axial, so it's kind of just more localized in the lower back or the neck. The idea is we do these test blocks in there. They're called medial branch blocks or sometimes facet blocks to figure out which areas has the pain. Once we're able to show that we can replicate that pain relief with that injection, then we can schedule them for a radiofrequency ablation, where the idea is we're doing a small lesion on the small nerve that gives sensation to that segment and temporarily blocks it for about 8 months to a year before it comes back. After that time passes, you can do another ablation, so again buys you more time. So for a lot of patients, having an injection once a year is enough. You don't necessarily have to have it fixed. If it's enough to kind of make you functional, do everything they need to do, and so once a year type of visit that comes to see us, then that's all it takes.
And you perform those?
Yes.
Lumbar, cervical, spine?
Absolutely, in all parts of the spine. And now these radiofrequency procedures we can do them in different peripheral joints. So the knee, the hip, sometimes it's the same strategy where we do a diagnostic procedure, block those nerves. They get patient gets an appropriate response, then we can lesion that. But again, it's for pain relief. We're looking for symptomatic improvement, hopefully functional improvement. But the degenerative process, that's what we're trying to block, this arthritic component. Sometimes people have a knee replacement, unfortunately it fails, that's one option. The hip, some people can have surgery. If somebody's very sick and they can't necessarily go under anesthesia to have a joint replaced, so surgery may not be an option for them. So we look at these other treatment options to help patients function and have a quality of life.
Yeah, I think that's a good segue. So we have patients too that they come in, they already had surgery, they already had fusions in the cervical spine and the lumbar spine. They've had replacements in their knees and their hips and all of their joints, and sometimes they come to us because the surgical option has already been optimized. What else can we do for these patients?
Yeah.
What would you do for somebody like that?
Yeah. So let's start with the knee, I guess, because you kind of brought that one up. Knee replacement, by and large, works a lot. Hip replacement, by and large, works a lot. But there are a fair number of patients that they follow up with the orthopedic surgeon. They take follow-up X-rays. The fusion looks good. The hardware is not loose. The surgeon's like, I don't know why you still hurt.
Surgery's perfect.
Right. The surgery looks perfect, and to defend them, it's perfectly placed. But doc, my knee still hurts. I can't do everything I want. We don't know why that occurs. Those in my head, it's an issue of a nerve that's been habitualized to fire pain, and so it'd be awfully nice if we could just tell that nerve, hey, we don't need to know about this knee pain anymore. It's structurally fine. It's been replaced. You can stop sending pain. Think of it like a phantom pain sort of thing, where somebody who's had an amputation sometimes will continue to have pain in that limb, even though the limb's not there. So how do we shut that nerve down? Well, we start oftentimes with diagnostic blocks, put a little Novocaine, maybe a little steroid in there, see if that calms that nerve down, shuts it off, like turn a computer off and turn it back on, and all of a sudden it just works fine. Oftentimes that'll work, but not last, in which case that ablation procedure is a great option, where we can put a very similar type needle, but one that's insulated with an uninsulated tip. Put a wire in that needle, and then hook up an electric generator to that wire, and then heat up the tissues right around and involving that nerve. It doesn't completely sever the nerve, but it takes the what's called the myelin coat off, which I describe as being like a plastic coating around a electric wire. So you kind of strip that coating down. When that coating's been stripped off, the nerve doesn't work. The body will remyelinate. It'll put a plastic coating around it again. It'll start firing again, and that's where every 6 months to 2 years, you got to repeat the procedure. If that works and lasts long, it's awesome. Sometimes, whether it's just the nerve replenishes itself fast, or it's just not enough of a traumatic event, there's techniques with what are called neurostimulators, where we can put little spaghetti strand like wires and then conduct electricity to them, and then you can permanently turn that on or off at your discretion to shut that nerve on or off. So these peripheral nerve stimulators are really gaining favor for patients who have chronic joint pains after joint replacement surgery, chronic neuropathies from nerve damage in the hands or in the feet. And then there's spinal cord stimulators, which is a similar technology for nerve fibers in the spine that are causing chronic pain, chronic firing. I don't know if you want to kind of comment on those, because I know you do implants, or you do the trials at least.
So to understand, chronic pain is a little different than acute pain. That's the thing I think people don't understand very well. So, and honestly, we don't really understand chronic pain well. We sort of understand it, but we don't really get it, right? It's something like the computer has gone haywire and we're not really sure, and restarting the computer may or may not work. We're not sure. But this neuromodulation idea is to sort of turn down the volume of the pain. The idea is that we stimulate certain parts of the spinal cord in order to override the other part of the spinal cord. So the peripheral nerve stimulator and the spinal cord stimulator essentially work in the same concept. It just depends on where we place it. So for the spinal cord stimulator, just like it sounds, it goes in the spine. So the idea is it blocks the signal from below the place where it's implanted to prevent that signal to get to the brain. So it either alters the signal or turns it off or sort of distracts it in some way. The first thing we have to do is make sure that this is an option for someone, but there is a trial period. So we're testing this thing out before we're committing to it, because it is an implantable device. It is an idea of a pacemaker for your pain. It's the best sort of concept I can give you. But the idea is we place the stimulator wherever the pain we think is causing the symptoms or loss of function, either it's the knee or the back or wherever. Place these wires up in the spine in that area for about a week to 10 days, depending on the practitioner, depending on the patient. And the battery, this generator, stays on the outside. So patients can experience what this device can do temporarily without committing to it. So in most insurance, pretty much all insurance, will pay for that option. So you get to try it out, you come back after a week or so, we take these wires out and then decide whether or not this pain relief and the function you had from this stimulation is worth putting this device inside you for good, right? So it's one of our, we kind of sort of say we don't want to say last resort, but one of our options we reserve down the road after maximizing everything else.
Yeah. Not a first-line treatment, but something that can be a rescue if you've had surgery and still have pain.
Yeah, and there's a lot of options with these too. Like typically for a peripheral joint, like a knee or a shoulder, stimulators are really small and the device is external. So you have the option of putting it on or strapping it on whenever you want to use it. Whereas in the spinal cord, you have the option of an internal device that we implanted in there, or also a wearable device too. So it depends on kind of what your pain is, how often you have it, what's your level of function, and how you want to use this device. So, and then like Dr. Farhad said, it's having that trial is essential because you get to see how it's going to be. It's like kind of try it before you buy it kind of a deal. And most people who have a really good trial really do well at the implant.
Yep. Yeah. So you wear that, like you alluded to, you wear it for a week.
Yep.
And whether you love it or hate it, those leads come out because they're attached to an external battery. And then if you love it, we schedule it for a second stage implantation weeks later. And then that one's a permanent implant. The batteries can be recharged. They last a really long time. Just depends on usage. But fabulous outcomes for people who oftentimes think they just don't have any other options. They've oftentimes given up. And somebody encourages them just to get one more consult. And nobody's ever brought up this idea of a stimulator. They're
Yeah.
fabulous devices. Again, not first line treatment, but fabulous devices for folks who continue to have pain after they feel like they've exhausted all their options.
And there's several different companies that they come out with new technologies all the time, and they update the battery and the software. And John was referring to certain companies now that have a wireless model. So there's not an implanted battery. It's just a wire. So a lot more of those are for peripheral joints, but the same company also does it for the spine. It's just like any other wireless device, right? So you would have a remote control that controls this device that's inside you. You get to turn it on, turn it off, etc. So, and most of them are MRI compatible. It kind of depends on the company, the battery, and what body part needs to be MRI'd. But most of them are MRI compatible.
All decisions we can help our patients make based on their own individual diagnoses, situations. Fortunately, all of us are fairly seasoned in that space and can really decipher all those different options to help our patients choose the best one for them.
We can go through a few questions
Yeah,
here.
good idea. We're kind of starting low on time.
So let's see. So Chip's asking, are these procedures covered by Medicare? I think generally yes.
Yeah.
Yes.
Yeah, I would say
Everything that we
you
talked about here was covered by Medicare.
Yep.
And then Judy's asking, does radio frequency work on shoulder pain?
You want to take that one?
Sure. So, excuse me, recently there have been a few studies that have shown radio frequency for shoulder pain, but the problem with the shoulder is there's not always a clear sensory component to the shoulder, right? So if you want to sort of, let's say, burn the nerve for the shoulder, well, it's not always going to be that particular nerve that controls the pain. So they have developed a new technique for the shoulder, but it's sort of the same concept. You know, test shots but from what I remember, it's not as good as the spine, the knee, or the hip. It's definitely the spine is the most studied part of the radio frequency treatment. You know, I would say.
Yeah.
My experience with the shoulder is the same. Like I've tried a couple of radio frequencies, haven't had great luck.
Yeah.
The peripheral nerve stim, on the other hand, seems to work really well. And I think that has to do more with, like you were saying, it's not so much cutting off the signal, like the radio frequency cuts off the signal. It's overriding that signal. And by giving that stim to the suprascapular nerve, that pain signal just gets overridden with this other vibratory sensation, buzzing sensation, that really prevents that pain signal from busting through.
Okay. Let's see. The other question is stem cell harvesting covered by insurance? So typically no for applications that we do here, which is primarily orthopedics, joint and spine issues. It is not covered by insurance.
Unfortunately, not yet. That's something we're working on as part of our data collection registry, proving outcomes as a society, nationwide society. That is one of our long-term goals, is to utilize data to support outcomes and then convince third-party payers this is something that would be good for their subscribers, as well as, to be honest with you, their bottom line. It's way cheaper than surgery, and we're on it, but it's not there yet.
Yeah. But if you come here, we can kind of give you all these options, whether it's insurance-based or out-of-pocket based. We try and optimize what's going to fit best for you based on your financial situation, as well as your overall health and kind of what your goals are. And we try and make that work for you here at the Michigan Center for Regenerative Medicine. I think that's all the time we have for now. Thanks for tuning in.
Yeah, thanks everybody. Dr. Parra, thank you for joining us.
Thank you.
And look forward to seeing you. If you think we can help, please give us a call, 248-216-1008, or you can reach out to us online, regenerativemedicinemichigan.com. We're in Rochester, Michigan, and love to take a look and see if we can help you.
Good night.
Good night, everyone. Thank you.
Good night.